It's really exciting too. I mean, a lot of us know each other, but it's great. We all take this really long course through like school and training, and we come across mentors, which Dr. Lawler was kind of alluding to, and you find you overlap and stuff with people. So it's really great to see Alippi, Dr. Bonham over here, having done his MD PhD at University of Washington, and then his neurology residency, and then his neuro-oncology fellowship, and then finally like launching into a career. But really, what's nice is this is a community. And I don't know many fields where, you have surgeons and radiation doctors and researchers and pathologists, and it really does feel like a community. So it's great to see him here and joining the community here. And I think we all want the same things, so it's just really, really great. I will add to Dr. Litvak's question that he asked that for a while there was an IL-6 brain penetrant inhibiting agent that was being studied for epilepsy. And I tried to encourage that company to look at it in gliomas because of some of the autocrine IL-6 reactions that occur in the gliotic changes, but I could not get them interested. But other people seem to be better at getting pharmaceutical companies interested in things than me. So I do want to talk about this because it's something that I feel like what we know has changed since I was in training. And then with a lot of the new updates, I feel like there's information that a lot of us were not taught and that I find clinically useful and interesting and potentially relevant. And I'm not really going to talk about NF. We all have heard about that. We know about that. We don't need to talk about that. So I just really want to talk about what I've learned over the last 10 years about germline mutations in brain tumor patients, because when I was trained, it was, this doesn't run in families. That's what I tell all my patients. And then we had a couple global studies, and a lot of us may remember Gliogene, that really seemed to confirm that, like, this is not a familial disease with rare exceptions. But I feel like what I've learned and some newer studies kind of question that or give us new light. So, I mean, really, if I was going to give you just like a one-slide talk, this would basically be it. There's now about 7 large-scale studies where they took every glioma patient, some just GBMs, some every glioma, and they ignored family history because we can do this now, and they took tumor and host or germline samples, and they just sequenced them. Are there any genetic germline genes that increased this person's risk of any tumor or cancer? And all of them are coming up with what to me are kind of alarming results, but the range is really like 2 to 14%. And this is not screening for family history, just patient had a glioma, we're testing their germline. And that's way, way, way above the normal baseline population. In some of the pediatric studies, some of these numbers go up to 20%, which is, to me, huge and really alarming. And a couple examples, and a couple of them broke it down. Like low-grade gliomas, the incidence seemed to be a little lower, but in GBM patients, the incidence was quite a bit higher. And part of why I think this is happening is now you can just run these panels, and you can screen hundreds of genes relatively cheaply and very reliably. And it's not any one gene. And I think that's why our prior studies missed it, because you used to only be able to test a couple genes at a time. And over the years, we've learned about more and new genes that predispose people to tumors and cancer. And in most of these studies, the cumulative percent, it's 1% of this gene and 0.5% of that gene. But the cumulative incidence is what really catches my attention. And then there's a couple studies now in medulloblastomas that are showing even higher numbers, which was not on my radar at all. And new genes are being described. So ATRTs are a rare tumor in children and young adults, but there are a couple studies now saying that the incidence of germline mutations in SMARC genes is not insignificant. And then pineoblastomas and other pineal tumors and pituitary blastomas. I think some of us have heard about the Dicer-1 syndrome, which I think Alippi was the first person to mention to me. I don't think I'd heard of it. But a lot of this stuff is out in the peds literature or the genetics literature, and it may not come to clinicians' attention. So that's really why I like talking about this, because I found it really helpful. And then there's a bunch of references, and they're all published, but Gliogene did not really find this. But then if you read it carefully, it kind of did. It was like, oh yeah, we found like 0.5% of these families had ATM, 0.5% had CHEK2. So they alluded to it, but those families that had multiple people with gliomas really might be a different population and a rare one compared to this. They did find some loci associations, but not any specific genes that are clinically available to test for. So the other thing I think that fools us is a lot of us learn like, oh, take a family history. But nowadays families are getting smaller and smaller. And sometimes these second-degree relatives, people say, well, they had cancer, but we don't know what it was because they didn't know back in the day or people didn't talk about it. But in a way, the recent studies free you from that. Like, yes, I take a family history, but I think a lot of these newer studies say, if I get a completely negative family history, I shouldn't just ignore this possibility. Some of the range can also be explained because some of these numbers are just really, really high, like 14%. And if you look carefully at those studies, they include genes that I think a lot of clinical geneticists would not include. So like MPH mutations are very common in the general population. But the biggest studies say if you only have one copy, you really do not have an increased risk of cancer. So some of these higher percentages included things and variants of unknown significance, which are unknowns. So to me, when you kind of remove those, the true incidence reliably from multiple studies in very different populations is coming up like 2 to 7%. And it is, again, this cumulative incidence. And what gets my attention there is that, most of us know, or hopefully know, that if a person in America or any developed country is diagnosed with breast cancer, the current, ASCO, NCCN guidelines basically say anyone diagnosed with breast cancer should probably be referred to the genetic testing. And the incidence of a germline mutation in a person with breast cancer, regardless of family history, is actually about 5 to 10%. So this is touching that range. So it makes me ask, if I'm almost or just as likely to find something as a breast cancer patient, should I maybe be referring all of my patients for testing? So that's kind of my question to you all, because it's what I ask myself. Existing guidelines do not address this whatsoever. So we'll get to that at the end, like, should we be changing guidelines for each other and for our patients? But if you look at all these different guidelines in different places and add them up, like I've done in this table, there's guidelines for when to test and suspect Li-Fraumeni. There's guidelines that most of us know about neurofibromatosis, von Hippel-Lindau, tuberous sclerosis. But the American Society American College of Medical Genetics also has specific guidelines that were recently updated about tumor mutations, which we talk about a lot. And I wasn't aware of this, but when I found it, I was like, are you kidding me? If I use this, I would probably be testing almost all of my patients. But I had never heard of this, so I don't think anyone else had either. And apparently my pathologists don't know it. But I look at these genes and I'm like, most of my patients have one of these in their tumor. So if you add all these different guidelines together, it almost comes to the same conclusion. They do have this interesting thing that modifies the tumor mutations for age that is basically because TP53 mutations are so common in brain tumors. And it says, well, if you're over 30, that's so common, and it's really looking for Li-Fraumeni. But other people have looked at this data and validated this, and I think a lot of us just aren't aware of it. So kind of already said all this. The other thing now is current testing, it's so much cheaper. And in the old days, you had to guess the gene because they'd only pay for 1 or 2 genes, and if you were wrong, oh well. But now you can get this huge panel, dirt cheap. Most of the testing in the US, they literally mail a kit to the patient, they swab their cheek and mail it back. I mean, it's that easy. Insurance typically covers it. As of today, there's a GINA law that protects patients from insurance discrimination based on genetic testing, but if that wasn't the case, I think there'd be a lot of other layers and concerns to testing people. And GINA, it isn't that old, it's still pretty new, so hopefully that remains in place. And then I think there's the question of, well, why? What are we going to do about this, right? So for me, the holy grail in cancer really is primary detection and prevention, which for breast cancer, maybe ovarian cancer, certainly colorectal cancer, it's led to huge, huge increases, in prevention of cancer deaths in people at risk. And to me, that's what this is about. That's the most obvious benefit. So if my patient is thinking of testing and they have any living relatives, to me, that's an obvious action item, because once a family is found to have a gene, then everyone related to them qualifies for testing and it should be covered. And we know what to do to protect them from other systemic cancers, not so much this. I think for some people too, they just want to know, why is this happening to me? Because I don't know why it's happening to them. And I think that's a valid reason for testing. If people are still in their childbearing years, like a lot of our low-grade glioma patients are. It can inform fertility testing, and there are options for people with BRCA and other germline mutations to do pre-implantation testing of embryos to screen out, which has some controversies to it, which I won't get into. And I think some of us, it's just too much to think about, well, what was their tumor mutation? What's their family history? What's the chance? The good news is you don't have to. That's why there's genetic counselors. We can't order genetic testing anyways. So if in doubt, I just say, just go talk to a genetic counselor. They're trained to do this. They have the data. I have found, though, that a lot of them are using slightly older guidelines. So some of them I will put in my referral note, P.S., here are my references. But so some of them will say like, oh, we don't have much data on this. You don't need testing. And I'm like, yes, you do. So I feel a need to direct it. And that may be why we should get together and update guidelines so that all of these patients should at least be offered testing. Because this kind of stratification thing is confusing, some institutions, including Sloan Kettering, are using just a super simple rule of if a patient has more than one cancer, that's not normal. And if anyone in the family has had cancer under 50, that ain't normal. That's not true for all genes. For BRCA, the age of onset of breast cancer really does stratify the likelihood of finding something. But for things like CHEK2 and ATM and some of the Lynch genes, that's really not true. Like, you're just as likely to find them in people who get cancer in what we think of as normal age ranges, like 60s and 70s, which is a lot of our GBM patients. So age isn't the only part of this story. So I think we were running a teeny bit behind. I have a few cases, but Alippi, don't let me run over and keep things on track. And I'm really informal, so please feel free to jump in, ask questions, interrupt. I can talk about all sorts of other things. I have a whole other talk I do for the epi students at UW about radiation and Agent Orange. And it's, again, this really interesting stuff. And I never learned it, but yeah. Anyways, I like to talk about stuff. So this is a patient of mine, 35-year-old guy. He had a prior history of a benign bladder wall tumor in his 20s, whatever. But then we're talking about his family, and he's like, yeah, my mom died of ovarian cancer. 2 of my sisters had ovarian and breast cancer, and they were all kind of on the younger side. So, that's a family history that should get anyone's attention, independent of him. And when I met him, he had had frontal headaches and a new onset seizure, and we saw this MRI. And I'd love to ask anyone except Alippi, because I know he knows this. Can anyone guess what this tumor is just based on the MRI I'm showing you? And what should we test him and his family for? Anyone want to take a guess? What is this tumor? Because I can tell you, I know what pathologically this is, and it's 99%. It's the most reliable imaging thing in radiology ever reported. And I'd love all of our surgeons to know this. So here is the T2 flare on the left and the T2 on the right. Does that prompt anyone? So this is something called the T2 flare mismatch sign. This was described over a decade ago now. And the name is a little bit confusing because a lot of tumors can have this bright on T2, not so bright on flare. But the other critical feature is this hyper intense rim that's thin all around the edge. That's not edema. And that's not a cyst, right? That's solid. There's little microcysts within it. So when you see this sign, this disparity between T2 and flare, that it mimics water, but you're like, that's not a cyst, that's not water. And it has that hyper intense rim. That is 99% specific for an IDH-mutant astrocytoma. It's not super sensitive. They don't all have it. There are case reports in the literature of people saying this is wrong. Everyone I've seen, I was like, but that's a true cyst, and it didn't have the rim. But when you have both of those features, it is 99+% specific. It can be any grade. It could be 2, 3, or 4. The 3s and 4s often have a little enhancement, maybe a little area of necrosis. But around that, you can often still see the remnants of this.
Jerome, what is it about an otherwise homogeneous solid tumor that causes this signal disparity at the rim, at the margin?
Yeah, so the reference down there, that's what we wanted to ask, because T2 flare, it's water, right? You're attenuating the water signal, but not fully. So we basically pulled all the path reports from all the IDH-mutant astrocytomas, And the ones that had this sign versus the ones that didn't, the pathologist often said that there was an abundance of microcysts. They were also more likely to have visible macrocysts on imaging, which would increase their water content. Makes sense to me. It disappears after radiation, but it does not disappear after a partial resection. Yeah, so just super interesting, because I always complain, like, imaging is not reliable, but like, there's one thing that is actually reliable enough you could make a decision. So with that family history, you'd think like, oh, this is a BRCA history, all this breast and ovarian cancer at young ages. But then he tells me, yeah, everyone said that, but my sisters got tested and they're negative. So what should we do with him now? Like, if we know his sister's tested negative for BRCA with that family history. So I said, who cares? Let's send you for testing anyways. And they'll test everything. And lo and behold, he came back for a RAD51C mutation. So RAD51C is a newer described mutation. RAD51C and D are part of the BRCA2 complex. So they behave like a BRCA2 mutation, lots of ovarian cancer. But when his sisters were tested, we didn't know about that. So of course they were negative. And it's much less common, but it's not super rare. And it's come up in multiple of these glioma studies, all the BRCA family genes. And I think what's interesting about that is we know that BRCA, breast and ovarian cancer patients with BRCA germline mutations, their tumors are much more sensitive to PARP inhibition, which we've done lots of studies in gliomas, and they haven't panned out so far. But I wonder if that holds true for our glioma patients. If they have a BRCA mutation, would it make their tumor more sensitive to PARP inhibition? No one's looked at it. So for some of these genes, I wonder if we might treat our patients differently, because that's certainly true in breast, ovarian, and colorectal cancers, that you have more treatment success if you know the germline mutation that caused it. So take-home point for this case to me was old testing should be repeated, because we get better tests, broader tests, new genes. Variants of unknown significance get updated. They get fed into this global database with family histories. And some testing companies now, and probably all in the future, are going to start doing protein modeling. So some of the testing companies, if there's a variant of unknown significance, they'll tell you protein modeling says that mutation probably does not change function, or that mutation is likely to change protein function. So you could start even stratifying variant of unknown significance. Is that just a nothing, or is that maybe real? And the ACMG recommends repeat genetic testing every 3 to 5 years for people who qualify for testing and prior testing was negative, or people where a variant of unknown significance was found. And I've had multiple patients now where we got repeat testing, and well, now we understand what's going on. So it's been pretty useful. So case 2, this is a 20-year-old woman with rapidly worsening headaches, hiccups and vomiting, strong maternal history of breast cancer in multiple people at young ages. And this is I think this is a T2 flare without contrast on the left, and this is a MPR, so a T1-based sequence on the right. Does anyone know what this tumor is based on this appearance? Lippy can chime in on this one, because I don't.
I'm wondering about a sonic hedgehog activated medullo.
Okay. Medullos can look so crazy. I have been wrong about them many times, especially on the left. I'd be like, I wonder if that's a medullo. She's a young person. Any other thoughts? So this is Lermita close, right? And we see medullos more, and I think of them more. But the key is, some people might look at that flare and say it, but to me, it's the T1 pre. It's this bundled, but kind of the cerebellar folia are kind of architecturally preserved, because this is within that foliar layer. People have called this like tiger striped, and if you pull up the right picture of a tiger, I guess I can kind of see that. So these are people with Cowden syndrome and germline P10 mutations. So Lermita close or dysplastic gangliocytomas, it is pathognomonic for this disease. So if someone has that, nothing else matters. You should suspect they have a P10 mutation and send them for testing. I've met one person who didn't come back with a P10 mutation. He did come back with a variant of unknown significance in another gene in the P10 pathway. So this is like a pathognomonic thing. It comes up on tests a lot for neurosurgeons and for neuro-oncs and neurologists too, really. So this is good test prep for anyone listening. They do have a significant increased risk of other cancers and breast cancer, and there's many guidelines. So this patient, based on her family history in this, we sent her for PTEN testing. She was positive. Based on that positive result, she got full body screening, and lo and behold, she already had an unknown breast tumor. This to me is the point of finding it in our patients is you start them on screening, and some of these people might be saving their life. But I've heard other people be like, well, what are you going to do with it? They have brain tumors anyways. But lermintoclose is a benign disease. So take home point, to me, germline testing is useful, even if it finds something that you as a neurologist or a neurosurgeon are like, that's not my job. Ideally, we find these people and can protect them, and that can be really useful, especially for the low-grade gliomas as they're living longer and longer, like decades. Case 3 is a woman in her late 40s who had survived breast cancer in her 30s with aggressive treatment and was doing well, but then presented with left-sided weakness. She had systemic screening, including a PET scan. Her ovarian cancer was in complete remission at this time. There was no family history. She came from a pretty big family, if I remember right. Anyone want to guess what this turned out to be? A bunch of people said MET, like it's a solitary enhancing lesion, it has edema, like even though her body's clean, she's had ovarian cancer. It's, how often do you cure ovarian cancer? But this was partially resected and it was a GBM. And then I was like, this is weird. You're young for a GBM. You had ovarian cancer at a young age. She had prior BRCA testing that was negative, so we sent her for testing, and she came back with Lynch syndrome. So she had an MSH2 mutation. Lynch syndrome, if you add up all the different genes, is actually pretty common in the general population. And 20% of Lynch genes, it's a new mutation. So you won't get a family history because it was a new mutation in that person only. I think a lot of us think of Lynch syndrome with colorectal cancer, which is true, but we now have big studies from Europe, and each mutation has its own risk profile. And MSH2 patients, their lifetime risk of a brain tumor was 8 to 20%, which to me was like, wow. Should we be sending these people for MRIs and screening? Within Lynch syndrome, it's also been shown that even within your mutation, family history modifies risk. So if you have, a MLH2 mutation, but you had a first-degree relative with breast cancer, your cumulative risk of breast cancer is higher than other people with the same mutation. And some of these genes, but not all of them, show anticipation. So age of cancer gets younger with subsequent generations who have the same gene. Am I okay for time? I think so. So case 4, this was an 18-year-old guy who had known NF1 and was being followed for a right neck plexiform neurofibroma, and presented with new onset seizures and left-sided weakness and this big enhancing cystic thing. So this was resected as a GBM. We know NF1 patients are at increased risk. The NF1 guidelines, which have been updated, so if anyone hasn't looked at them in a while, I encourage you to look at them because they've been updated based on big natural history studies, often done at Mass General, but also at CHOP. They do recommend brain plus minus spine every 1 to 2 years. UBOs, these little non-enhancing flare things, are really annoying. They cause a lot of stress, but they're usually nothing. But we now know their pattern. Like, this is where they are. So it's easier to me to follow them. But any new enhancing brain lesion in an NF patient is a glioma until proven otherwise, a malignant glioma, not just optic nerve gliomas. Their risk is higher than the general population. Most of them don't get it. But that's really, to me, the take-home point from the NF1 patient guidelines, because sometimes you've been doing this for years and you're like, yes, I know they have the neurofibromas. So we do primary glioma screening in this one disease. And then maybe the last case I'll show is a 32-year-old woman with a prior history of breast cancer. Her sister died of breast cancer, and that sister's daughter had a sarcoma of the proximal leg. Patient tested positive for a TP53 mutation. So this is a good family history, not good, but this is a family history of Li-Fraumeni. So This was already known. And then she was sent, as some people with Li-Fraumeni are, for whole body MRIs, which is kind of becoming the way to monitor NF and Li-Fraumeni patients. Rather than getting 10 different tests that still don't look at everything, just do the whole body MRI and find it all at once. And lo and behold, on her whole body MRI, there was this little thing in her brain. So she was fine. They decided to watch it. But on her 2-year follow-up, it was bigger. So that's when she got referred to me. And we said, like, you have a significant risk of gliomas. This is growing, and it's in a fortunately very accessible place for the surgeons. So she went ahead and had this resected, and it was an IDH-mutant astrocytoma. So we might be, and I've met 3 Li-Fraumeni patients now where we identified a glioma pre-symptomatically on whole body MRI. So this may become a thing. And in a perfect world, if we think resection really benefits our patients, maybe we should be doing it for other people at risk. Because if it happens to pop up somewhere you can resect it, that theoretically would be the best thing to do. And these are all patients I've met just in the last couple of years. So it's not like I was picking through. Like, I think this is as common as the studies are saying. And the more I've sent people for testing, I feel like I'm getting a similar rate to what's reported in the studies. There's a million other genes. Like, I don't want to talk about all of them, but because to me, it's simple as a clinician. I'm just going to send my patient for testing, and they're going to find whatever. And then once you know the gene, then we have data. What are you at risk for? How should we protect you? The one thing that I've had recently, I've had 2 people with tuberous sclerosis with malignant gliomas, which is not supposed to happen. These are not SAGAs. And there's only a few case reports in the literature, but I've had 2 this year. So if anyone else has had any tuberous sclerosis patients with a malignant glioma that's not a SAGA, like, let me know, because I think we should report this. Other thoughts? Oh, variants of unknown significance. These are really annoying, but some people do protein modeling, so that's helpful, because you can be like, that does not change protein function, who cares? Or that changes protein function, and I have a patient or family history that kind of makes it seem like this is real. And it's reporting those variants of unknown significance with the patient and family history. That is how these global databases get updated. So if you are adding that through your geneticist to that database, you are helping other people with the same variant be like, this many people in the family had that variant, none of them had cancer, probably benign, or hey, the people in this family with that variant seem to have problems. We're updating the database so everyone can benefit from this information. And the people with a variant are the ones that really should get repeat testing every 3 to 5 years. And sometimes it's not even testing, it's just seeing their genetic counselor, checking the database for new information. So I'm getting to the point where I feel like maybe a group of us should get together and update the guidelines through SNO, ASCO, NCCN, because I think the data has accumulated and crossed a threshold that is comparable to other cancers where we send for testing. I feel like I knew none of this, and in fact, I was trained and told these don't run in families, you don't send them for testing. So I really feel like I've learned something new, and it's helping my patients. But I feel like most neuro-oncs don't know all this new information, so I want to update other people so they can use it as well. And then I think, to me, one of the next steps would be to say, like, for some of these genes, do Lynch patients with gliomas respond better to immunotherapy? Do glioma patients with a BRCA mutation respond better to PARP? It'd be hard to do those studies, but we could also go to prior studies, and if we have the samples, see how many people in that huge PARP inhibitor study actually had a germline BRCA family mutation. Do they seem to be outlier responders or not? So we could even dig through old data and maybe get a hint at the answers to those questions. So I'm only, I think, a teensy bit over, so I'll stop there. Thank you so much. I really appreciate the opportunity to share this, because we're always learning new things. We're always hoping we learn something useful or helpful for our patients. So I feel like this has really helped me and some of my families. So thanks for letting me share it. Any questions?
Yeah, I'm just curious. Are you noticing differences in what you're picking up based on where you're sending it? This is a conversation I've been having with Dr.
Yeah, when a variant is found, I like seeing the protein modeling on the report, but But again, that's all theoretical and extrapolation. And I have found that some genetic counselors are like, yes, this person should get testing, even though they don't meet my old guidelines. But some genetic counselors are kind of sticking to their guidelines that exist. And then I'm having to be like, well, go see this other genetic counselor.
Well, I meant even in terms of platform, like genetic testing platform.
No.
Okay.
No. There are some companies that will dual test. So if you're sending a tumor for mutation analysis, some of them will also test germline genes at the same time if you send a paired sample. Is that better, more efficient, more cost effective? I don't know. I have no idea. Thanks so much.